Cerebral Edema in Diabetic Ketoacidosis by Dr. Michael Agus.
Hi and welcome. I'll be speaking today about diabetic ketoacidosis, or DKA. My name is Michael Agus. I'm a pediatric intensive care doctor and a pediatric endocrinologist at Boston Children's Hospital. I'm the director of the Medicine Critical Care program here at Children's and an assistant professor at Harvard Medical School. Now, what does a patient succumb from? What do they die of? In general, cerebral edema.
Literature review.
There have been three major studies in the literature over the past several years, fairly large studies, but retrospective, totaling about 11,000 patients. And together, they seem to demonstrate that there's about a 1% incidence of significant cerebral edema among patients who present with DKA. Among those who get significant cerebral edema, about 40% will die or have a severe neurologic outcome. If you do the math, that's a net population mortality of about 0.4%. A more recent study by a colleague of mine here at Children's, Dr. DeCoursey, looked at a FIS database review. FIS is an administrative database we have access to in the US. Was able to look at a total of just over 37,000 DKA patients in a single study. And to our surprise, we found a significant increased incidence of significant cerebral edema, defined as edema that prompted therapy of either mannitol or hypertonic saline by a practicing clinician. Fourfold increase in the incidence, but a 10% mortality. So a significantly reduced mortality. And on the face, that looks like good news. We're treating more patients and they're doing better. But again, when one does the math, basically we haven't changed the ultimate mortality at all. We're treating 4 times as many patients. They're one quarter as likely to have a bad outcome, and ultimately 0.4% population mortality. So despite our advances over the decades, it's not clear that we've made a major impact in overall mortality. But these numbers are low, and it's easy to have had even a 30 or 40% effect on mortality and have that really be difficult to detect with these studies.
Risk factors for cerebral edema.
What are the known risk factors for cerebral edema? Well, again, back to Dr. Glazer's paper from 2001. She identified 4 major risk factors in children with significant cerebral edema. 3 of them are shown here: a high BUN, a low PCO2, and treatment with bicarbonate. Now, we know that a high BUN is associated with someone who's dehydrated. How about a low PCO2? That's someone who has a very low pH and they're hyperventilating and dropping their PCO2 so that they can blow off some of that additional acid. And who gets treated with bicarbonate? Those who have the lowest pH. So although these were independent risk factors, the reality is that all 3 of them correlate really quite directly with severity of illness. And while they may be independent risk factors, as clinicians, we look at patients and our message is the more dehydrated, the more acidotic they are, the more at risk they are. The 4th risk factor was the one that really kind of threw us for a loop. 4th risk factor, if you notice, demonstrates a lower relative risk when the serum sodium rises by more than 5.8 per hour. The prior 3 risk factors I showed you, if they were true, the relative risk is increased. In this case, when it's true, the relative risk decreases. What that suggests is that a serum sodium rise of 5.8 per hour is a good thing. Now, we measure serum sodium every 2 hours. And that would mean that we would have a change of almost 12 millimoles per liter over a 2-hour period. That means patient comes in with serum sodium of 125. You check it again a couple hours later, it's 137. That is an extraordinary change. And as a clinician, I would posit that this is not, in my experience, a degree of change in serum sodium that we see very commonly at all. So what do we do with this risk factor? Do we just does it only apply when the serum sodium rises so dramatically that to an extent that we almost never see? Instead, we can look at it from a little bit of a different point of view. If you come over here and look at this graph, I'll show you what I mean. So if we look at the evolution of sodium and glucose concentrations over time in the setting of DKA, we can think about it from a point of view of being above and below normal. So if we consider this to be the normal range, and we start with a glucose concentration that's quite high, we know from our discussion that the serum sodium will be relatively low. And the idea in resolution of DKA is that as the glucose comes down into the normal range, the serum sodium ought to rise. The reason the serum sodium is low to begin with, you'll recall, is that glucose is an osmotic agent that pulls water into the bloodstream, diluting everything that's in the bloodstream. So it's going to dilute sodium, it's going to dilute potassium and chloride as well. But sodium is the most obvious, the most prominent. And as glucose comes out of the extremely high range into the normal range, the exact same thing ought to happen with sodium. The risk factor that we were discussing earlier is when glucose begins to come down, but sodium does not come up at the same rate. If sodium comes up a little bit and kind of flattens out, that is considered the invocation of the risk factor that sodium has not risen fast enough. And this is considered a risk factor for developing significant cerebral edema. One way to follow the relationship between the hyperglycemia and the hyponatremia over time is to look at the corrected serum sodium. One way to think about the sodium changes that we talked about are to look at a value that we refer to as the corrected sodium. Corrected sodium answers the question, what would the serum sodium be if glucose was normal? We use a formula to calculate this, and we say, we take the serum sodium and look at the serum glucose, and we say how many hundreds over 100 is the serum glucose, and multiply that times 2, and add it to the serum sodium, and we get our corrected sodium. For example, serum sodium is 125 and the blood sugar is 900. Well, that's 8 hundreds over 100. So 8 times 2 is 16. We add 16 to the 125, we get 141. So the corrected sodium in this example is 141, while the measured sodium is 125. A question that's often asked in this situation is, which is real? Which is the real serum sodium? The answer is very definitively that the serum sodium is 125. The sodium that the brain is seeing, it's 125. What would the sodium be if the glucose was normal? 141. But the glucose isn't normal. The glucose is 900. And so right now, the serum sodium is quite low. The way we use the corrected sodium to think about this risk factor is to say the corrected sodium should be normal and stay normal. If, as we saw in the graph, the glucose comes down and the serum sodium does not rise adequately, that should be reflected in a corrected sodium that is low. So if the corrected sodium drops below 137, 138, we really need to get ourselves to the bedside, do a thorough neurologic exam, and determine whether or not this patient has symptoms of significant cerebral edema, and think about treating at that point. But this risk factor is really only present when the serum sodium does not rise sufficiently. Now you may ask, why would I not just give sodium? Well, there's nothing, I don't have any data to suggest that one should not treat this scenario with sodium. But I will tell you that every study that's ever looked at rate of sodium administration has not found it to be a predictor of significant cerebral edema. We are physicians, and when something is low and it's a bad sign, then our inclination is to treat it to bring it up. The best example, the best analogy I could think of is a patient with meningitis. Let's just say that an 8-year-old has meningitis and has a CSF white count of 10,000. Now you know that a high CSF white count is a very poor prognosticator and a significant risk factor. I will give you the choice. You can either treat this patient with ceftriaxone or you can plasmapherese the CSF. Which are you going to choose? You're going to choose the ceftriaxone because you understand that the problem here is that there are bacteria that are eating part of the brain and causing a massive amount of inflammation that is putting the patient at risk for a severe outcome. The white cells are only a symptom of the underlying pathology. I would posit to you that that is really the exact same thing that's going on here. When the sodium fails to rise normally, it is not the problem, it is a symptom of the problem. And it is very likely connected to inappropriate ADH secretion that is triggered by an injured brain and a brain that is becoming more and more either ischemic or significant swelling with significant pressure building up, triggering release of ADH and inability to allow the kidney to clear adequate free water. That doesn't get any closer to a treatment approach, but it does point out that the failure of serum sodium to rise has not been shown to be a component of the pathology, rather a symptom or a sign of the pathology. Having said all that, when we see serum sodium fail to rise or a corrected sodium that begins to drop, the right approach, because we don't have any better data, is to increase the concentration of sodium chloride in the fluids that we're delivering. And we'll talk about that more in a minute. The other findings of this study were interesting in that there was a whole slew of risk factors that were not identified as being significant. You see those on the screen, and importantly, they include initial glucose. It's very helpful for clinicians over the years to understand that a glucose of 1200 is no more risky than a glucose of 600. What matters is the degree of acidosis, degree of dehydration, the factors that we talked about before. As of this study, giving an insulin bolus didn't attribute increased risk. The rate of insulin infusion didn't seem to matter. Rate of IV fluid, even the rate of sodium administration, as I mentioned. One important caveat to a retrospective study, however, is that one can only measure within the range that was done. Now, rate of IV fluid, for example, was not shown to be a significant risk factor. But in animal models, we know that if we give a massive amount of fluid to patients with DKA, we will engender a lot of significant cerebral edema. And so why did that not happen here? Why was that not noticed here? And I think the answer is that patients in this study didn't give a massive amount, didn't receive a massive amount of IV fluid. And as a result, in a retrospective study, when one is practicing within reason, you may not pick up a lot of unreasonable practices. There was a similar study done by Dr. Julie Edge in Europe. She found similar risk factors, but two slightly different ones that are worth mentioning. One is she noted a trend towards higher risk in younger patients, and that's something that intuitively we believe, that a younger patient with a full diaper and good urine output is not considered to be sick patient, and we see that all the time. And also that new onset diabetics are at higher risk for developing significant cerebral edema, again, presumably due to delayed presentation because the families are not skilled in noticing the symptoms of evolving DKA.
Diagnosis of DKA.
Now, a patient is admitted, they're in your unit. What signs are you really looking for to diagnose cerebral edema at the time and to consider therapy? Well, Dr. Mir reviewed a bunch of really severe cases and came up with a set of diagnostic criteria. Now, I don't advocate for the strict use of this particular protocol and particular formula, but the lists are quite helpful and quite informative. On the diagnostic column, we have some symptoms that I think all of us would jump in and treat pretty instantaneously. If a patient is unresponsive to pain, if a patient has decorticate or decerebrate posturing, if a patient has a new cranial nerve palsy, and finally, if they have a neurogenic respiratory pattern, which is really something close to agonal respiratory pattern. And of course, that is the third component of Cushing's triad. The second component being bradycardia, and Dr. Mir actually quantifies this as a change of greater than 20 beats per minute from baseline. And then the first component of Cushing's triad, which is actually extremely common, is hypertension, quantified by him as a diastolic blood pressure greater than 90. Despite patients presenting with hypovolemia and dehydration, they curiously have increased systemic vascular resistance, increased tone, and have relative hypertension. The other major risk factors are interesting. Significantly altered mentation, mental status, and then age-dependent incontinence. This one struck me when I first read the paper because patients will often come in the evening and at night, and you take a 5-year-old who's been toilet trained and give them the worst night of their life to keep them up all night. You give them a huge amount of fluids, they have a pH of 7.1, and they wet the bed. Is that really meaningful? And it turns out from this data that it is. And so that's become one additional item that we focus on in our hospital, and that nurses and house staff are really quite attuned to. The minor criteria are pretty common. Vomiting, headache, lethargy, not being easily aroused. In my own estimation, when I do a neurologic exam for a patient, I will stimulate the patient to whatever extent they need. But if even after significant stimulation they are then able to answer questions appropriately, meaning birthday, where they are, what they're doing here, name, that sort of thing, then I tend to allow their mental status to be characterized as acceptable. He also noticed that children at a young age were at increased risk, as we've seen before.
Development of DKA.
When does one get the significant event, the cerebral edema? Well, in Dr. Glazer's paper, she noticed that several had it when they walked into the ED, meaning it can't be true that all significant cerebral edema is related to therapy. And it leads to the idea that there's something about the patient, something about, we mentioned before, the size of the skull, the amount of extraaxial space, and it may have more to do with the severity of the acidosis and how long they've been ill. All these factors we haven't been able to identify, but what we can tell you is that some patients will get significant edema without any therapy. The bulk of events, meaning development of significant edema, occur within the first 6 hours. By hour 12, 13, you're really largely out of the woods, but there are some stragglers, and those tend to be patients who just aren't quite responding fully. Their course ends up being a little bit longer than you might expect, but those are few and far between.
Therapies for DKA.
Now, what happens if we believe we have a patient with significant cerebral edema? We have a blown pupil, we have decorticate posturing, we have a patient who's unresponsive. Well, then we need to call for our appropriate supports, local supports, hospital supports, so that if we do need to take an airway, we're able to do that. But we also call for the appropriate therapy. Now, what is the appropriate first-line therapy? There are two competing therapies out there right now. One is mannitol, and one is 3% hypertonic saline. while 3% hypertonic saline has some reasonable data that's been reported with it in traumatic brain injury, there are hardly any data reported in the use with its use in diabetic ketoacidosis. As a result, and also as a result of some data I'll show you in a minute, I use first-line therapy as mannitol. We use 1 gram per kilo. We infuse it over 15 minutes. Please remember that mannitol sitting on a shelf for a long period of time can form some crystals, and so when one draws it from the vial, one needs to use a needle with a filter. It is very well tolerated. It does result in increased urine output during the hours that follow, and so one has to keep track of that hypovolemia that may follow mannitol administration. Second-line therapy, if mannitol does not work, is 3% saline. There is some debate on what the actual recommended dose of 3% saline is. An equimolar dose to the mannitol dose that we've used over the years is 5 ml per kilo. Again, we infuse it over 15 minutes. However, in this particular case, if a patient's mental status improves, I would halt the infusion immediately. One does not want to run the risk of central pontine myelinolysis by acutely raising the serum sodium any further than needed to restore a reasonable mental status. If the patient does not respond and they lose their airway reflexes, intubation may be warranted, and one wants to use an agent that takes into account the increased intracranial pressure, for example, thiopentol with or without the use of lidocaine. After intubation, I would hyperventilate down to the end tidal CO2 that the patient had prior to losing their mental status. Hyperventilation, while not a standard therapy for increased intracranial pressure and cerebral edema, is exactly what this patient has been doing for many hours prior to losing their mental status. And so while one doesn't want to go beyond what they were doing, one wants to go back to what they were doing and then slowly raise it over time as they would do if they were conscious. Finally, a head CT is really not necessarily part of the algorithm. The decision to treat ought to be made based on clinical symptoms. The head CT can show significant cerebral edema on virtually any patient with DKA. And so the presence or absence on CT is not going to guide therapy. If a patient has edema but is alert and awake, you're not going to treat. And if a patient is obtunded and non-responsive and the CT is negative, you are going to treat. And so again, treat based on clinical symptomatology. The debate between mannitol and 3% saline really is an active one. And in looking at some retrospective data over the last decade, it looks like in the United States, the use of 3% saline has gone up quite dramatically, especially in the last few years. However, in looking at the survival or the odds ratio for survival when using one therapy over the other, there is a hint in this admittedly retrospective database study that there's an increased mortality with the use of hypertonic saline as first-line therapy. That has contributed to our decision here to use mannitol exclusively as first-line therapy.
Therapies for DKA Update.
At the end of 2013, we published a retrospective analysis of mortality in DKA, which revealed some new data which is worth considering when choosing a therapy for cerebral edema in DKA. The study looked at a total of 43,000 patients with DKA in an administrative database. Patients were identified as having cerebral edema as a complication of DKA based on the codes that physicians and hospitals build at the end of the admission. We were able to identify patients who had a CT scan as well as those mechanically ventilated or admitted to an ICU. Over the course of a decade, it became clear that the use of 3% hypertonic saline has gone up dramatically over the last few years. While starting close to 0% in 1999, it had gone up to roughly 50% of cases by the year 2008-2009. Concomitantly, the use of mannitol as solo therapy has gone down. The use of the two together remains relatively infrequent. Over that same time period, mortality in patients with DKA has also gone down quite significantly, from 0.47% in 2000 to a low of 0.08% in 2009. This is a logistic regression taking account the effective discharge year adjusted for hospital clustering, and is statistically significant. The odds ratio of mortality in patients treated for DKA when looked at mannitol versus hypertonic saline is in fact increased slightly with the use of hypertonic saline alone to an adjusted odds ratio of 2.7, which is statistically significant even after taking into account other significant factors such as male gender, use of mechanical ventilation, and CT scanning. This has allowed us to create some additional thoughts that should be considered when treating someone for DKA. It's noted that this is the largest retrospective study that's ever been conducted in DKA, and that over the decade that was studied, the rate of treatment for cerebral edema has increased fourfold, while the overall mortality in DKA has decreased by 80%. However, this decrease was not associated with the marked rise in use of 3% saline as therapy. In fact, there is a slight increase in mortality among those who receive 3% saline after conducting an adjusted analysis. These data ought to be considered when choosing a rescue therapy for cerebral edema in DKA. Thank you very much for listening and look forward to interacting with you online with any questions that develop. Thank you.
Please help us improve the content by providing us with some feedback.